Hi everyone, today we'll be learning about gestational trophoblastic disease. So this gestational trophoblastic disease is mainly a proliferative abnormality of the trophoblast. So we all know that when the blastocyst is getting implanted in the decidua, this in situ and cytotrophoblasts are going to develop all over around it. So and this structure here is the structure of a tertiary villi. So and when the villi is going to have some hydropic changes, the trophoblasts are going to be swollen and abnormal. That is what is called as gestational trophoblastic disease. So it's usually a benign disease of the chorion, but it has malignant potential. That is why we're very concerned about a molar pregnancy. So this gestational trophoblastic disease can be classified into two types. Can be either benign, so this pre-malignant is also called as benign here, and we have the malignant gestational trophoblastic disease, which is also called as gestational trophoblastic neoplasia. So coming to the benign disease now, we are going to be focusing mainly on molar pregnancy today. So and it is of two types. One is your partial mole and the other is complete mole. And there are two other benign forms also. EPS is exaggerated placental size and PSN is atypical placental site nodule. So if any of these benign disorders, they can anytime become malignant. Okay. So the malignant forms are choriocarcinoma, invasive mole. PSTT is your placental site trophoblastic tumor and ETT is epithelioid trophoblastic tumors. So now we'll be focusing more on molar pregnancy alone. So coming to this slide. So why is the name called as hydatiform mole? Have you ever thought about it? It's because this picture right here is looking like droplets, is it not? So this word hydatista, it is a Greek word which means droplets of water. You can see that all the placental villi, they are so much hydropic and they contain so many cysts which contain fluid. That is why we have taken the word hydatiform. And the word mola in Latin means false conception. So it's actually not a pregnancy which is viable. That is why the name hydatiform mole has been derived for this condition. And this slide. So we all know how a normal embryo is formed, right? And what is the chromosomal content, number of chromosomes we know. So sperm is going to carry 23 chromosomes, and when it meets its egg, which carries 23 chromosomes, a diploid embryo is formed. The chromosomal number is going to be 46 and it is diploid. So we all know about this. So what happens in molar pregnancy? Why suddenly only the trophoblast is proliferating in an abnormal manner? Why is the fetus not viable in this condition? The reason is because, first coming to the complete mole, the ovum here you can see, right? It is empty. Then empty ovum is going to be fertilized by a sperm. So and when what happens is, sometimes two sperms simultaneously fertilize an empty ovum, or a single sperm fertilizes and then the sperm's chromosome becomes duplicated. So ultimately, the chromosome number is going to be 46. But the thing is, it's completely paternal chromosomes. There is no maternal contribution here. So we all know that maternal contribution of chromosomes is very important for fetal tissue formation. So because the maternal component is missing, the pregnancy is going to be abnormal. Only the trophoblasts are going to proliferate abnormally here. That is a complete molar pregnancy. So remember in mind, it is a diploid pregnancy. It contains 46 chromosomes, but still the pregnancy is not going to be viable. Coming to partial molar pregnancy. So here what happens is, the ovum isn't empty here. The ovum also contains 23 chromosomes, but two sperms or three sperms can simultaneously fertilize an ovum. So what happens here? The chromosomal number will be 23 into 3. That's going to be 69. So it's going to be triploid. Okay, 90% of cases it's going to be triploid, but in 10% of cases where three sperms are simultaneously fertilizing, it can even be tetraploid. Okay, that is what a partial molar pregnancy is. Many of you would know what this is. This is a picture of Lord Shiva in the Sartanarishwarar form. Okay, according to Hindu mythology, Lord Shiva took a form where half of him was by Shakti, that is his wife, and half of him was Lord Shiva. So this is to show to the world that both men and female are equal. And in a world, you need both equal contributions from both of them. So that is what happens in each cell of a body also. You need both maternal and paternal chromosomes in equal number to have a normal viable pregnancy. So whenever the mother's chromosomes is absent or there is going to be domination of male, just like in life, how it's not going to work out, it's not going to work out in pregnancy also. Okay. So coming to the hydatiform mole, complete hydatiform mole. So coming to hydatiform mole, we have already discussed that it's going to be diploid in 90% of cases. It's going to be 46XX. This is a karyotype. This is also an important MCQ. So here two things can happen. First condition is called as androgenesis, which means a single haploid sperm which has fertilized the ovum, it can multiply into two. So that is how two 46 chromosomes are there, but still everything is going to be paternal in origin. So that process happens in 80% of cases. Androgenesis happens in 80% of cases, whereas in 20% of cases, two sperms can fertilize. Again, the result is going to be the same. So in 90% of cases, a karyotype is 46XX. In 10%, it can be 46XY or 46XO, but this X is going to be paternal in origin. So this is a gross pathology of a complete mole. You can see that there is extensive trophoblastic proliferation. Fluid-filled vesicles are seen all over the placenta. And this is what is going to be present. There is not going to be any fetus here. So a complete hydatiform mole. So the villi are going to be enlarged and dilated and edematous. The villi will be vascular and hydropic villi will be present. There can be cavitation seen inside the villi and there will be trophoblastic hyperplasia. You can see that the trophoblasts are proliferated much. This is a histopathological picture of a complete hydatiform mole. So in this picture here, so this is a picture of a snowstorm. So in a dark background, you are seeing so much of white spots. That is how it's going to resemble in USG. So complete mole has snowstorm appearance in USG. This is an important question again. Coming to partial mole. So we already saw the partial mole is going to be triploid. It is important to know this. And the chromosome number is 69. The extra set of chromosomes is usually derived from the father. Here the ovum also contains chromosome material and two sperms are going to simultaneously fertilize. So the ultimate chromosome number it's going to be 69XXX or it can be 69XXY or 69XYY. Okay. So this is the cross pathology. So the fetal tissue is going to be present in partial mode. That because we have maternal contribution here. So fetal structure develops, but still it is not compatible with life. So because whenever there is a fetus, you will obviously have blood vessels. Okay, and the trophoblastic proliferation won't be much like in a complete hydatiform mole. So this is the histopathological picture. You can see that. So all these structures, these are the blood vessels. Blood vessels are going to be present. The trophoblastic hyperplasia won't be marked. You can see that there is not much proliferation of the trophoblast, but there will be some inclusions within the villi structures. Okay. So coming to the USG picture, it's going to resemble mostly a missed abortion. Most of the times the cardiac activity is going to be absent and you can see the hydropic change in the placenta. So partial mole usually resembles a missed abortion. Okay. So what are the risk factors? Who develop this molar pregnancy? We have to know about this also. So the incidence is going to be maximum in Asia and South America. And in Asia, it's maximum in Philippines. The incidence is 1 in 80. Okay. Whereas in India, it is 1 in 400. All these are important points. So the risk is very high in either very elderly women or in teenage pregnancies. And low socioeconomic status is very common. And if there is a history of molar pregnancy, then the chance of recurrence is high. It is 1 to 4%. This again is an MCQ. So any diet deficient in protein, folic acid, vitamin A, all this results in molar pregnancy. And suppose a patient gives you history of familial pattern. She says my siblings also have molar pregnancy, even my mother had a molar pregnancy. In that condition, you should think of a missense mutation in NLRP7 locus on chromosome 19. So this again is an important question here. So whenever there is a missense mutation in chromosome 19 in this NLRP7 locus, there is chance of repetitive hydatiform mole. So what are the clinical features? How the patient present to us? So it is a pregnancy, right? But the pregnancy has gone wrong. So usually how the presentation in pregnancy is going to be, there will be a period of amenorrhea. So the same thing is going to be here. That following this period of amenorrhea, the patient can come to either with bleeding per vaginum. Sometimes he will even tell I have passed something like cystic structures per vaginum. this history can be there, and she can have abdominal pain. So that abdominal pain, it can be because of this overstretching of the uterus. There can be any hemorrhage because of these molar pregnancy. Sometimes there can be a spontaneous uterine perforation if there is an invasive mole. Sometimes the mole can invade the uterine walls. If there is any infection, or the uterus can be trying to contract and expel out the contents. The patient can even present with features of preeclampsia and thyrotoxicosis. This is thyrotoxic is because beta HCG is very high in this condition. Because of very high beta HCG, we know that the beta HCG resembles TSH hormone. So that is why there is thyrotoxicosis. And preeclampsia is because of all the placental problem. Placenta is the main pathology in preeclampsia, right? So because the placental trophoblasts are abnormal here, they present to you with features of preeclampsia. So when you do a per abdomen examination, the size of the uterus is going to be more than the period of amenorrhea in a complete mole. That is, she will give you history of only 8 weeks amenorrhea. But when you do a per abdomen examination, it can be even 16 weeks gestation. Okay, that is how much big the uterus will be. And the uterus will feel firm, elastic, and doughy in consistency. So because there is no amniotic fluid inside it, fetal parts will not be felt. The patient won't give you any history of quick. And when you do a vaginal examination, allotment is not going to be present. So when the uterus is 30 weeks size, you will obviously think there is a baby inside, right? But there is no allotment present. Sometimes what will happen, the ovaries can contain THECA lutein cyst, which is very common in 25 to 50% of cases with molar pregnancy. And when you do a PV, even the vesicles can come out per vaginally. Okay, so this is what the finds in vaginal examination. So what are the investigations we want to do? First thing we want to do a routine full blood count because there can be a chance of concealed hemorrhage and everything. Do a full blood count. Main thing is do a blood grouping and typing because these patients can land up in hemorrhage anytime. So do a blood grouping and typing, send the blood for cross matching, reserve blood and keep it in hand. Okay. Hepatic, renal, thyroid function test. Everything is important because I have already told you there is more chance of thyrotoxicosis. So send a thyroid function test for the patient. Do an RFT and LFT. Both are very important again. That is because I told you there is chance of severe preeclampsia. Next important thing is chest X-ray. So I'll tell you, come back and tell you why it is important. And then we are going to get an ultrasonography done. In ultrasonography, in a complete mole, we have the snowstorm appearance. In partial mole, it's going to resemble a missed abortion. And most important of all, beta HCG is going to be very much high in this condition compared to a normal pregnancy. So you have to do a quantitative estimation of the human chorionic gonadotropin. So why chest X-ray was important? That is because even though I have told you that molar pregnancy is a benign condition, it can metastasize to the lungs. Okay, these are called as cannonball mets. So this is a cannon, right? It resembles a cannonball. Cannonball mets, metastasis. So this is very common in your molar pregnancy. So get a basal chest X-ray done. So what are the complications which can happen? The patient can go into hemorrhage. If there is severe hemorrhage, she will end up in shock. There is chance of sepsis. The uterus can get perforated if there is an invasive mole, or during an evacuation process, we can perforate the uterus. There is going to be severe thyrotoxicosis, preeclampsia, and because of sepsis, hemorrhage, and everything, she can land up in DIC also. And sometimes what will happen, the vesicles, small vesicles, they can even enter into the uterine circulation and they can reach the lungs and they can cause acute pulmonary insufficiency. Embolism can happen. So whenever hypertension occurs less than 24 weeks and the patient has never had an ultrasound, always better to get an ultrasound to rule out molar pregnancy. There will be hyperemesis gravidarum. Okay. So this is the difference between complete and partial mole. Complete mole is generally diploid. Partial mole is generally triploid. The hydropic villi trophoblastic hyperplasia is going to be diffuse. Whereas in partial mole, it is going to be only focal. Only in some places there will be hydropic villi. In some places there can be trophoblastic hyperplasia. Scalloping of villi in fetal embryonic tissue. So that is going to be present in your partial mole and P57 expression. So this P57 is always maternally expressed. So P57 expression is going to be present in your partial mole. This again is an important question. So remember P for P57 partial mole, it is going to be positive. Coming to the clinical presentation, partial mole in USG it's going to resemble a missed abortion, whereas complete mole, snowstorm appearance will be present in USG, which we already discussed. Uterine size is going to be small for gestational age, whereas here it is important it is large for gestation age in your complete mole. THECA, LUTEIN cyst and medical complications are very high in your complete mole, and the chance of malignancy, that is maximum around 15 to 30%. It's common in complete mole, whereas it is only 1 to 5% in case of partial mole. Coming to THECA LUTEIN cyst. So because of high circulating levels of HCG, in 25 to 60% of cases of complete mole, the cyst can be present in both the ovaries. Okay, it is yellow and colored. Usually after suction evacuation, it regresses spontaneously, but it does not need any specific management. But sometimes if it undergoes a torsion or infection or hemorrhage, then you may need to perform an oophorectomy. If not, just leave it alone. It will resolve spontaneously. Okay, this is a picture, ultrasound picture of THECA LUTEIN cyst, and this is the surgical picture. Okay, coming to the management. So how should we manage a case of molar pregnancy? Now, you have done an USG and you're sure it is a complete mole. So what will you do? The best option is suction evacuation for a complete mole, irrespective of the uterine size. Okay. So if the cervix is open, what you will do? You can just directly start with suction evacuation, and once most of the molar tissue is removed, then you can give oxytocin if necessary. If the patient is going to bleed or something, then you can give her oxytocin. Usually avoid any uterotonic during an evacuation of molar pregnancy because the chance of an embolus is going to be more. Whenever the uterus is going to strongly contract, some of the vesicle contents can enter into the bloodstream and they can go and cause a pulmonary embolism. Whereas if the cervix is going to be tightly closed and you have diagnosed on ultrasound a molar pregnancy, then what to do? We can give any ripening agent. We can give a vaginal misoprostol, and then once the cervix is ripened, then we can proceed ahead with the suction evacuation. Coming to a partial mole, I already told you that there is going to be fetus in a partial mole. So imagine there is a fetus of 10 week size in it. It is not easy to aspirate a fetus leg in suction, right? So in those conditions, then you can prefer using medical management. Okay, once a patient expels the products, maybe then you can suction it out. And if there is going to be any severe hemorrhage, then you can even land up trotomy or hysterectomy. Okay, but whenever the question is about molar pregnancy, always go ahead with suction evacuation. Okay, I'm just showing you a video of a suction evacuation being performed. The USG here is showing characteristic snowstorm appearance, and there is no fetal tissue. So usually when the fetal tissue is going to be so big, then you have to go for medical termination of pregnancy rather than directly going for suction evacuation because you won't be able to suction the fetus out. And it's always better to do suction evacuation under ultrasound guidance for a case of molar pregnancy because the uterine walls will be so thin and there is chance of perforation of the uterus. So that you do it under ultrasound guidance. So you can see that. So just notice this picture. You know the bladder, right? It is at the base of the uterus, that hypoechoic structure which you see over there. And the uterus is so big. But as she is going to suction all the products out, you can see that the uterus size is also coming down. And now she has almost come to the end. Almost all the products have got suctioned out. And you can see the uterine wall also contracting along with that. So you can appreciate how well the uterus has contracted following suction evacuation. All the products, we have to do an ultrasound scan and you are going to check whether you have left out any remaining products or not. Okay, so now we are sure that all the products have been curated here. Perform. Now I have done suction evacuation for my patient. So how am I supposed to follow up it? Is that the end or something else should be done? This is the question now. We have to do regular follow-up because we already told that it is a benign condition, but there is more malignant potentiality, especially when it is a complete mole, there is 15 to 30% risk of developing into a malignancy, the gestational trophoblastic neoplasia. So the follow-up is must in cases of molar pregnancy. So on each visit, we have to ask the patient if there was any irregular vaginal bleeding, any cough, which will indicate that there is any metastasis to the lungs or not. Ask for any complaints of breathlessness or hemoptysis. Always do an abdominal vaginal examination to see if the uterus has involuted well. If there was a THECA LUTEIN cyst, then estimate the ovarian size also in your examination and look in the vaginal wall. So it can even metastasize to the vagina. So look if there is any malignant deposit in the vagina. So usually by 2 months, theca lutein cyst will regress. Okay. So and pelvic examination should be done after 1 week of molar evacuation. So investigations in each visit, we are going to follow up the patient using HCG and chest X-ray may be necessary if the patient is going to develop any symptoms. So how do we follow up with beta HCG? Well, first, to understand this follow-up better, so I have done an USG or whatever. I have diagnosed a case of complete mole and we have done a beta HCG also. So it was some 3 lakh. Then I went ahead and done with a suction evacuation. So once I did suction evacuation, after 48 hours, I'm going to repeat a beta HCG. This is going to be my baseline value. So okay, let us keep it as 1 lakh. So immediately post evacuation, it has become 1 lakh. And after this, what we will do, we will start repeating beta HCG on a weekly basis. So maybe on week 1, 2, 3, 4, 5, you can keep it. So on week 1, it has already become 50,000. On week 2, it is only 10k. Week 3, you are seeing it has become 3k. So on week 4, it has become like 500. On week 5, it has already become some 20. So, less than 20, we keep it as it is normal. Okay. So, once it has come to normal, then again we'll keep repeating weekly. So, if 3 consecutive values, it is only 5 or less than 5 or whatever on 3 consecutive values, then we are going to start repeating in monthly. So, for a complete mole, usually beta HCG gets reverted within 56 days. So, the follow-up is going to be for 6 months from the date of uterine evacuation in such cases. But if the HCG doesn't revert to normal within 56 days, then you have to follow her up for 6 months from the normalization of HCG, which means my patient, I did suction evacuation. So starting from today, within 8 weeks, 8 weeks is 56 days, right? The beta HCG has normalized, beta HCG has become normal. Then I will follow her up only for 6 months, starting from the day of uterine evacuation. So from this day for 6 months, in total, I'm going to monitor her. Whereas my patient's beta HCG did not normalize within 8 weeks. It took 10 weeks only she has normalized. So in those cases, from the week the beta HCG normalized, from that time we have to monitor for 6 months. That is a difference in both. Okay. So if it is less than 56 days, you will follow her up for 6 months from the date of evacuation. If it is more than 8 weeks, it is more than 56 days it took for the beta HCG to normalize, then you will follow her up for 6 months from the normalization of HCG. So according to recent guidelines, this is for a complete mole. According to recent guidelines, for a partial mole, once the beta HCG has returned to normal on 2 samples, 4 weeks apart, you can just stop the follow-up. You don't have to do it for 6 months. So today I did a sample, it is normal. After 1 month, I am repeating another sample. It is normal. Then there only we can stop the follow-up in a partial mode because the risk of malignancy is very low here, only 1 to 5%. Sometimes patient may need prophylactic chemotherapy. So almost 80% of the patients, they are going to go into spontaneous remission following a molar pregnancy. So we don't have to give prophylactic chemotherapy unnecessarily because all these drugs are going to cause the patient premature ovarian failure, menopause and everything. So the beta HCG fails to come to normal by 10 to 12 weeks, or again if there is a re-elevation of the level after reaching the normal, the patient is having persistent hemorrhage, or the patient is not going to come to you for follow-up. There is any evidence of metastasis in chest X-ray or any vaginal nodule if you are able to see, or when the patient is a high-risk patient. In these conditions, you can go ahead and give a prophylactic chemotherapy even though molar pregnancy is a benign condition. Okay. So the chemotherapy regimen we are going to give, it is only a single drug regimen. We are going to give methotrexate 1 mg per kg per day IV or IM on day 1, 3 and 5 and 7. Along with this, we are going to give folinic acid to bring down the side effects of methotrexate. 0.1 mg per kg IM on day 2, 4, 6 and 8. So we are going to give at least total of 3 courses. And when you are going to give the chemotherapy, the beta HCG level should decrease by at least 15%. So how to advise the patient regarding contraception? For next 6 months during the period of follow-up, patient should not become pregnant. So why the patient should not become pregnant? That is because whenever a female becomes pregnant again, the beta HCG is going to increase. So how will you monitor? The beta HCG will be elevated because of the pregnancy, That's why we tell the patients not to become pregnant at least for 6 months following evacuation. So we have to advise her some contraception. Usually we don't prefer an IUCD because there is more risk of perforation and risk of bleeding PV also an infection. So we don't prefer an IUCD. Can advise her barrier contraceptives, but that is not going to be the first line because there is more chance of failure. She can start herself on OCPs once the beta HCG returns to normal. Okay, not before that. And DMPA injections are best option or progesterone implants. These both are best options you can advise. But nowadays you get these kind of questions, right? Picture questions with case scenarios. The scenario here is a 28-year-old primary gravida and she comes to OPD with complaints of irregular vaginal bleeding with 2 months of amenorrhea. Abdomen examination shows uterus of 20-week size. USG was done, which shows the following picture. All of the following are true except. So look at the picture first. So you're able to see the bladder in front and behind it we have the uterus. The uterus inside the uterus, it's not normal. This much we know. And we'll just read the options. Her HCG levels are very high. Her TSH may be increased. Her BP may be high. Her HCG levels will be lower than normal. So with the case scenario, we can come to a diagnosis of molar pregnancy. And the USG is again confirming it. It is a case of complete hydathiform mole and the USG picture is a snowstorm appearance. So we know that the HG is going to be very high in case of molar pregnancy. So first answer is not the option. And TSH will be increased because we have told thyrotoxicosis is common. So this is also not the answer. BP will be high. Again, preeclampsia is very common in patients with molar pregnancy. So coming to the last option, HCG levels will be lower than normal. That is the right answer here because that is not true. Coming to the next question, the percentage of complete moles progressing to persistent GTN. So it's 1 to 4, 4 to 8, 8 to 12 and 15 to 20%. The answer is 15 to 20%. The risk of hydathiform mole recurrence in a future pregnancy is 1 to 4%. So all these things you have to remember, it's very important. Molar pregnancy is a very interesting topic for me personally, but because it takes some time to understand the concepts. So I guess this presentation would have made it simpler for you. But still, if you feel that some concepts should be told in a different way, or if you're not clear about something, then please text me in the inbox. I'll be glad to help you out. Thank you so much.